All right, hello everyone, and welcome all to the third webinar in the Pediatric Kidney Transplant series, hosted by the Saudi Organ Transplant Center, sponsored by AstraZeneca, and organized by EG Group. My name is Dr. Al-Shami. I'm a pediatric transplant nephrologist from King Fahd Specialist Hospital, Dammam, in the Eastern Province, and I'm one of the members of the Kidney National Allocation. I'm one of the 2 pediatric representatives. I'm really honored and happy to host this webinar with the 3 eminent speakers in the field of pediatric transplantation. Our webinar will be 90 minutes long. We will have 3 presentation or maybe 4 presentation. I'll have a very quick 5 minutes presentation. Our 3 speakers each will have 20-minute presentation. And at the end, we'll have a good at least 25 to 30 minutes for discussion. During the webinar, please, if you have any questions, just post your questions in the Q&A box, and we'll try our best to answer it at the end. The title of our webinar today is Should Pediatric or Children be prioritized in the Disease Donor Allocation Waiting List? And basically, our objective is to discuss the ethical grounds of behind giving children priority in the list. We also would like to review the existing policies, practice regarding organ allocation, and to emphasize on areas that needs to be changed, area needs to be critiqued or reevaluated. And most importantly for us, the most important questions to be answered is what does it take to give children priority in the disease organ list? So I will share my slide. I was asked to give a little background of what we are doing in the kingdom. So is my slides clear? Everybody can see it?
Yes.
Okay. So I thought I would just walk you through the journey of the Saudi Center of Transplantation establishment. So the first kidney transplant from living donor was back in 1979. And in 1983 was the first National Kidney Foundation Center was established. And only in 1990 was the first liver transplant program established. And our first lung transplant program was established in 1991. And only until 1993, the National Kidney Foundation name was changed to SCOT, which is the Saudi Center of Organ Transplantation. SCOT is the kind of regulatory body for organ donation, organ allocation. It oversees all the process, and it's also oversees all the transplant program in the kingdom. Not only this, it participates heavily in education, in campaigns, in addition to policies, procedures, and legislations. So up until 2000 last year, we had around 2,091 organ transplanted in the kingdom, and there was a significant improvement in the percentage of kidney organ transplantation from living donors. The increment was up to 30% last year. And if you can see here, back in 2023, 2 years ago, we had total of 414 organ transplanted from deceased donor, 181 kidneys, 59 heart, 3 intestine, and 77 lungs. And from the start of our program back in 1979 until now, we have a total of 17,833 kidney transplant performed in the kingdom. If we compared ourselves to the world, in terms of living donation, our program is more than 97% depends on living donors. And we rank second after Turkey in terms of donation after donation in living donors. And it was 46.4 per million population. However, if you can see, when it comes to disease donor, we are on the bottom of the list. We're doing only almost 4 per million population, and this data is from last year according to the IRA data from the Donation Transplant Institute. Up until last year, we have around 20,500 patients on hemodialysis, and you can see that the numbers are increasing, and there's a huge gap between an imbalance between demand and supply. And the trend is going, and the average annual net increase on a yearly basis is around 5%. And if you look at the among those, we have around 6%, 124 children on hemodialysis as of last year. And similarly, patients active on peritoneal dialysis in the kingdom until 2021 are around 2,000. And out of these 2,000, 247, 13% were children. So as I mentioned, huge gap, huge scarcity in organs. The number of the trend in possible disease donor patients, if you can see, the trend is not increasing much. We are doing small progress and small steps over the years, but overall, I think we have a lot of work on progress. And you can look at the huge gap between patients on the waiting list versus available kidneys and organs for transplantation. And this is data from 2022. We had possible 623 donors, and at the end, we were just able to consent and utilize 112 out of the 623. And so I think as a community, we don't have a problem with the concept of transplantation, but when it comes to donation after death, I think here is the problem, and here is the where we should put our work on donation after death. So just quick scheme about how things works in the kingdom in terms of kidney distribution. Allocation of organ does not follow HLA matching because our program is very small. Our pool is very small. In KSA, a center-wise distribution model is the basis of organ distribution. And to be honest, there is no standardization. Each center has their own system, but I believe all of us, the most determinant and important factor for giving points is the waiting time on dialysis. Although it seems fair, but it seems like a queue. Come first, served first. I don't think it's fulfilling the purpose of allocation, which is, I don't think we have a clear plan and we don't have a clear purpose. But I believe there is huge room to improve as long as we are open-minded, as long as we are open to challenge our boundaries. That's why we are here openly discussing our allocation and hoping to change and learn from what other people are doing. So extended criteria donor are only offered to adult, and the pediatric population, we are just getting 20% of standard kidney. And the definition of standard kidney are any kidneys that is not extended criteria. And we are only allowed to get 20% because we contribute the least. Our percentage is around, as I showed you, maybe not more than 2% from the pool. So we are given only 20%. So in cases of any problems, we go back to Scott to solve any dispute. And again, this is the first kidney go to affiliated center, and the second kidney will go to the pool. Currently, there is a huge change, huge transformation in Scott with the new leadership, Dr. Talal Al-Gofi, and we have a lot of new established committees, and this is for the first time. I'm really happy and glad that the committee included pediatrics, and I'm one of the 2 pediatrics represented in the committee. We are trying to do KDPI, and this is the US system, but still it's a work in progress, and we don't know exactly. We are working on it and see whether it's going to suit our population or not. Here's just to show you that we have an active transplant center. We have 13 governmental transplant center. We have 1 transplant center that does all organs, including intestine, pancreas, kidneys, hearts, and lungs. Another center is doing other organs, and majority of the centers in the kingdom are doing kidney transplantation. And we have only 4 centers in the entire kingdom who does pediatric kidney transplantation, and only 2 centers for liver pediatric across the kingdom. So this is my question, naive question, that I'm very advocate for children, and I wish that children will get priority in the waiting list. And I want to ask the panel, what does it take? What's your experience to give children priority in disease donor waiting list? So our next speaker now, I'm really honored to introduce Dr. Emily Perito. Dr. Emily Perito is a professor of pediatrics at University of California, San Francisco, in the Department of Pediatric Epidemiology and Biostatistics. She is gastroenterologist and transplant hepatologist. She's a very strong children advocate, and she is presenting the advocating for children at national level at the US. She is the current chair for the Pediatric Transplantation Committee at UNIS. She's also chair of the Society of Pediatric Liver Transplant Advocacy Committee. She's done a lot of research work, and one of her area of interest is how to give children, especially liver transplant children, the priority in the list, and how to advocate for fair allocation for them. Our honor and pleasure, Dr. Emily, to have you. So the mic is yours.
Thank you. It's really my honor to be here. Thank you so much for having me. I'm going to go ahead and share my slides. Is that working okay? And dive in. I'm going to try to give you guys some background on pediatric priority for deceased donor allocation for solid organs in the United States. I am a gastroenterologist, so my real expertise is in liver transplant, but I'm going to try to do my best to explain how kidney transplant works as well as other organs, and I may turn to the other panelists for some help with questions later on, particularly around kidney-specific stuff. Just brief disclosures. I actually just wrapped up my 2 years as chair of the United Network for Organ Sharing Pediatric Transplantation Committee, in which we think about policies that affect kids, again, across the deceased donor organ transplant waiting list. I've also just listed here companies from which I have research grants and do consulting for. None of these impact what I'm going to talk about today. Objectives for my talk: I'm going to give a very brief history of pediatric priority in the U.S. deceased donor allocation system, give you an outline of what current status of pediatric priority in the U.S. looks like and how we work that into our allocation system, and then talk about some changes that are coming in the U.S. system as we sort of transition over to what we're calling continuous distribution, and I'll explain more about why and what that looks like. So pediatric priority for deceased donors in the U.S. is really embedded in the foundational regulations of our national system. In 1984, that's the first time that the U.S. kind of organized nationally the transplant system. And this was done under the auspices of something we call NOTA, which is the National Organ Transplant Act. This was legislation that established a national network to oversee organ transplant. And that national network is called the Organ Procurement and Transplantation Network, or OPTN. And NOTA itself, the language of the law, really charges the OPTN to recognize the differences in health and in organ transplantation issues between children and adults, and to adopt criteria, policies, and procedures that address the unique healthcare needs of children. A couple of years later, in 1986, is when the contract to actually run the Organ Procurement and Transplantation Network was awarded to an organization called the United Network for Organ Sharing. That's one national nonprofit organization that oversees allocation policy and implementation of this policy and maintains the National Registry for matching. There are some system changes happening currently, but since 1986, UNIS is the organization that has been overseeing and helping run the transplant system in the U.S. It took several more years, but in 2000 is when the sort of finalized U.S. Department of Health and Human Services regulations were set up for some more detail about how transplantation ran, and we call that the final rule. It governs OPTN structure, role, and policy principles. So I think the important piece of this is that there really was a commitment from the beginning of the organization of a national system to recognize pediatric priority and the need to treat children a little bit differently in this system. This is a high-level overview of how UNOS works, how we make policies for deceased donor allocation, and changes to those policies over time. UNOS has several committees. That includes a pediatric committee, which includes representation from across the organs, as well as patient and family like recipient and donor representation, and representation from the organ procurement organizations, which are not the individual organizations that actually procure the deceased donors across the US. And so we think about pediatric specific issues within the system, and we interact with a lot of the other committees. The most important for policy making are the organ specific committees: liver, intestine, kidney, lung, heart, and pancreas. We also have an ethics committee, which provides guidance across, as well as some others that I think are less relevant for today. But these committees work together under a policy oversight committee and a board of directors to help make the policies that govern deceased donor organ allocation. And this, again, is a high-level overview of how that policy development works in the US. We start usually by one of the committees or someone in the community coming up with an idea about a current problem in the way that allocation works, or disparities in outcomes or access. The committees and then the board will first consider whether everybody agrees this is a problem that needs to be addressed. And then we do evidence gathering. We're really fortunate in the US to have data on every candidate that gets listed for transplant and what happens to them during the listing process, through transplant, and afterwards. It sounds like you guys may have a similar system set up. And I think that having that data on everybody is extremely important for really being able to analyze how the system is working, and then to be able to model using statistical stimulation what might happen if we make changes in the future. And so we do a lot of that in this policy development process to try to predict as well as we can what the implications of policy changes will be. Once the committee and the board decides that they're happy with a potential policy change, that goes out for public comment and is presented across the US in different meetings, as well as available online so that the community can evaluate and comment on that. There are often some adjustments that get made after that, and then it goes to the board and then is eventually implemented after it's approved. I will say another important part of this is what we call the post-implementation review. So in setting policy changes up on that sort of orange, pink, purple side of the circle, we also include in that the plans for what we're going to follow in the data after implementation, to try to really understand, did this policy make the changes that we were hoping it would? Is it working how we think it would? Were there any unintended consequences that we might have to rethink? So then this feeds back in, I think, to that circle of recognizing initial adjustments and then changing policy as we go through. This is not the fastest process, but it is meant to really, include as much stakeholder input from transplant centers, from the organ procurement organizations, from the recipient, as well as donor families and other stakeholders, so we can, again, really try to adopt policies that are going to work for the system as a whole. In terms of what pediatric priority in the US system looks like, I'm going to give you kind of a high-level overview of how it's worked in, and then I'll go into the more specific organs, particularly kidney, what it looks like. So in the US system currently, children 0 to 18 years of age at listing for transplant are considered within the pediatric priority. And so that continues if a child is listed before they're 18 and then they turn 18 while on the listing, they continue to have pediatric priority in the system. For some organs, for example, liver and lung, we give some extra priority for children 0 to 12 years of age. This is particularly to give because they often require smaller donors. And so to help kind of prioritize or facilitate that matching. Pediatric priority is integrated into two main places. One is the allocation priority score, which determines how the child is ranked against others on the wait list. That's calculated a little bit differently for each of the organs. And the second is in the deceased donor allocation algorithms. So that's sort of the categories of donors that kids might get access to. And the goal is to really give children the preference for the best fit donors. This may be by size. For example, small children may need a smaller kidney or a smaller heart, or expected longevity, because kids are expected to live for much longer than many adults after transplant. So we want to try to match so that organ has a good endurance also. Now, I will warn you before we dive into this that our system is relatively complicated compared to pediatric priority systems in some other countries. And so I think you may hear about, that more as we hear about the Canadian system, but keep in mind that this has gotten a little complicated over time. And so not necessarily, I think, something you want to exactly mimic as you have the opportunity to set up a new system. I'll talk first about U.S. pediatric priority for kidney. Since 2014, we've been using what's called the kidney allocation score. As I mentioned in that policy development process, it can be a little bit slow. So it took about 10 years to develop this process before implementation. And the goal of the kidney allocation score was really meant to improve longevity matching, which is to align the expected survival of the kidney with the expected survival of the recipient. There's two main components that goes into this: the KDPI, which is meant to reflect the longevity, the longevity and health of the kidney itself. It sounds like you guys may be using something similar. And the lower KDPI equals, or is intended to equal, a longer anticipated function after transplant. So children currently receive priority in the U.S. system for deceased donor kidneys with a KDPI of 35 or lower, and these are likely to function longer than 65% of all kidneys offered in the deceased donor system. We also consider the EPTS, which is the expected post-transplant survival score. This relates to the recipient, and a lower score equals longer anticipated patient survival after transplant. This actually represents an area where we've tried to keep things a little bit simpler for pediatric priority. So all children receive the lowest possible EPTS. It's not calculated based on patient factors as it is in adults. We just assign them the lowest EPTS because, when we looked at the data, kids survived so much longer generally than most adult recipients that seemed to make the most sense in the system. Now here's a little bit more about the allocation scheme for a deceased donor kidney. The allocation scheme for the kidney is based on its KDPI. Several factors then go into sequencing the potential recipients for that kidney. Candidates are grouped into categories based on distance from the donor. Age, HLA sensitization is something that we use, and then their expected post-transplant survival. And within each of these categories, candidates are ranked by a priority score, which you can see on the right. That's based on their waiting time, their distance from the donor, and their HLA sensitization. And so again, as I sort of mentioned, this system gets pretty complicated, but the within that pyramid of categories eligible for a deceased donor kidney, this reflects KDPI less than 20%. You can see with the orange arrows a couple of places where pediatrics are slotted in for priority. We also have some priority baked in as we define in the priority score the start of time spent waiting. So adults have to have a GFR of less than 20 milliliters per minute or be on dialysis to have their waiting time kind of kick in and start counting that towards priority. Children can be counted as sort of starting waiting time once they start dialysis or once they're registered on the waiting list. And so again, this is sort of a small change meant to encourage some or allow for some preemptive transplant of children before they end up starting on dialysis. There's very similar pediatric priorities for kidneys with KDPI 20 to 35%, with children still receiving high priority, but children do not necessarily receive priorities for kidneys with the higher KDPIs currently in the system. I'll go briefly over again how this pediatric priority is baked into other organs. In pediatric, in liver, we use what's called the PELD and MELD score. The PELD is for pediatrics, the MELD is for adults. These are allocation priority scores that are meant to reflect medical urgency, as we don't have dialysis, and so waiting time is a little bit less important in liver. And the PELD was recently updated based on data we'd been collecting over the last 20 years to better capture children's waitlist mortality risk. There are also, so the Peld and Meld points are used to rank people against each other on the wait list. But there are also ways to increase the Peld and Meld score by exception, which are extra points that can be awarded for standard criteria for different common scenarios. I think the metabolic diseases is a good example, or request to the National Liver Review Board, which is run by UNOS. Children are prioritized currently for pediatric deceased donor livers, again, to increase access given their small size. And an ongoing challenge we have in liver is really figuring out how to incentivize split liver transplantation so that we can use, one segment of a liver for a small child and leave the other segment available for either another child or an adult. Similarly, in heart, allocation is based on your status, which reflects medical urgency categories. I've given you some of those criteria here, as well as blood type for matching and distance of the donor from the recipient for kind of logistical reasons and ischemia time. Children now have priority for pediatric donor hearts. And as you can see here, I won't go into the details, but all children are last listed as status 1 or 2 for medical urgency. And the adults can be listed status 1 through 6. So this, again, kind of bumps children into the higher priority categories by making sure that their medical criteria are a little bit different than what adults are waiting for. Now, as I mentioned, this can get a little bit complicated. So currently this system, the production of the match run, so for a particular kidney, which candidate actually gets offered the organ is automated, but this happens with some, I think, still kind of complex and clunky tables that have thresholds where there's cutoffs between categories. Just to give you an example, for kidneys with a KDPI of less than 20%, there are several tables that you go through matching these different categories that end up determining what the match run looks like and who that deceased donor organ actually gets offered to. These were essentially created when our technical ability to do these calculations and sort things in an automated way were not as advanced as they are today. And so we are going through a big system change inside UNOS, where we're gonna across organs change how the US allocation priority for deceased donors is determined and move to a system called continuous distribution. In continuous distribution, you will have a composite allocation score for every recipient. You can see the general categories in the boxes on top here. So the composite allocation score will include a number of points that recipients get in different categories. That may include medical urgency, post-transplant survival, candidate biology. These are things like their HLA sensitization, patient access, which I'll show you going forward what that looks like, placement efficiency. And you can see just a sort of hypothetical example here in the bottom graph where the candidates A, B, C, D through G each get an amount of points in each category. And that adds up to a total composite allocation score, where then the person with the highest composite allocation score for that kidney, based on all of their component scores, will be offered the kidney first, and so on down the list if they refuse. I'll give this example of US priority for lung because they actually moved to a continuous distribution allocation system in March of 2023. And so this is what their composite allocation score is made up of in lung. Their medical urgency is determined by 1-year waiting list survival without a transplant. Their post-transplant outcome is determined by expected 5-year post-transplant survival. They chose to use something called reducing biological disadvantages, which also goes along to sort of biological components that impact your access. So that counts blood test. CPRA is panel reactive antibodies, and then height, which reflects, that if you're a small person, then you need small lungs. In terms of patient access, pediatric priority is embedded here, and that's the intention for each of the organs, as well as being a prior living donor will give you some priority. And then in terms of transplant efficiency, that is where the distance between recipient and donor comes in, and there's different ways to define that. Again, I put sort of orange arrows here to highlight, even though there are specific priority points that will go towards just being in the pediatric category, there are a number of places in these continuous distribution systems where pediatric candidates might get additional priority kind of baked in. In terms of deciding how much each of the categories is worth, each of the categories or measures has what we call a weight to it. This sort of reflects the total priority points you can get in this category. And it's meant to reflect that maybe waitlist survival is the most important. In lung, they've decided that waitlist survival and post-transfer survival should be sort of equally weighted, and that those things are much more important than you can see at the bottom here, something like proximity efficiency, what the distance traveled is. So 25% of your score could come from waitlist survival, 25% from post-transplant survival, but only 5% could ever come from travel efficiency. Pediatrics in lung weighed out somewhere in the middle. And the way that we've determined what these weights should be is a combination of a couple of things. One of them is what we've called a values prioritization exercise, which is a stakeholder survey. UNOS has sent out surveys to mostly transplant providers, but this was publicly available. So also OPO representatives, recipient families, patients, donor families, to try to get a sense of what the community thinks about which candidates should be prioritized and how much. We also have used statistical modeling to look at the impact of how these things are balanced against each other to try to make sure that we're not disadvantaging everybody, that folks still have access. And so you can see here a summary of the results of the values prioritization exercise for lung, in which the stakeholder community, including transplant providers, felt that increasing access for patients under the age of 18 was basically as important as prioritizing the sickest candidates first to reduce waiting list mortality. And so that then fed into the weight of pediatric priority in this composite allocation score. Kidney is in the process of developing their continuous distribution plan and their composite allocation score. And this is taking place over a sort of cycle of discussions within the kidney community, and then feeding things out for public comment, and then going back and continuing to adjust, as well as integrating statistical modeling. This is what the hierarchy of kidney attributes is currently looking like. There will be pediatric priority points inside the patient access category. And then, as I mentioned before, there's other places where kids can get some priority. For example, we anticipate that the EPTS will still be included in the composite allocation score. And so again, kids get pretty high priority within that expected post-transplant survival. And so there may be some cumulative impact there. These are the results of the values prioritization exercise for the kidney community, in which the community overall, and we've also looked at breakdowns of different group members here, thought that, again, that the priority for a pediatric candidate should fall kind of in the middle of different categories, a little bit less than medically urgent candidates, which in kidney is, as you guys well know, a pretty sort of small slice. That's people who are about to lose dialysis access, but much higher than folks who have been waiting a long time. So to summarize, the U.S. organ allocation system really embeds pediatric priority for deceased donors, especially access to pediatric donors. We consider children, those who get pediatric priority, those who are 0 to 18 years of age at listing for transplant. And pediatric priority is currently integrated into allocation priority scores, which is how the child is ranked against others on the wait list for a particular match run, as well as in the deceased donor allocation algorithms, which tries to give children preference for the best fit donors by size or expected longevity. As I mentioned before, and you may hear as you hear about the Canadian system, this is relatively complicated, compared to the systems in some other countries, particularly across Europe, where they sometimes give pediatric priority for all donors, or extra allocation score points for children to simply bump them up, ahead of most adults. Or for liver, I think is a good example in terms of thinking about split livers. Kidney could be an example of this in terms of one kidney going to, one person and another going to someone else, where in several countries, they now mandate allocation of suitable livers as splits, where they allocate it to two different people. And often that's one to a child and one to an adult, to try to ensure that we take care of the kids in a prioritized way on the wait list. Thank you for your time. And I think hopefully we'll have time for questions and discussion later.
Sure, yeah. So we'll leave the questions and discussion till the end. Thank you very much, Dr. Perito, for your comprehensive presentation. So our second speaker is Dr. Erin Whiteman. Dr. Erin is a professor of pediatrics in the Division of Biostatistics and Palliative Care. He's a pediatric nephrologist, and he's adjunct associate professor of bioethics and humanity at the University of Washington School of Medicine and co-director of education at the Truman Cart Center of Pediatric Bioethics and Palliative Care. Dr. Whiteman's research interests focus on medical decision-making for children with complex disease and chronic medical condition. He is the founder and the chair of ethics committee at the American Society of Pediatric Nephrology. He also serves on the OPTN Pediatric Committee and recently served on the OPTN Ethics Committee and EPTA Ethics Committee. Welcome, Dr. Whiteman. The mic is yours.
Thank you for the kind introduction, and thank you to the organizers for inviting us to participate. And I am very much looking forward to our discussion and chances to learn more. As mentioned, my name is Erin Whiteman. I'm a pediatric nephrologist and bioethicist, and I work at the University of Washington and Seattle Children's Hospital in the US. Does my slide deck look okay?
Yes.
Not hearing any. Okay, great.
Yeah, it's clear.
I don't have any financial disclosures, but I do have a couple of disclosures that I think are important. The first is to be clear that the views that I'm sharing are my own and do not strictly represent the views of the Organ Procurement and Transplant Network or United Network of Organ Sharing, which are the American version of SCOT, where I serve as an unpaid volunteer on multiple committees, or the International Pediatric Transplant Association, where a few of us serve as volunteers. I think actually more important in terms of disclosing is to recognize that I'm a parent and a pediatric transplant clinician who practices in the United States of America. I work at a high-resource, busy transplant center. And I personally feel, in part because of those things, that children should be prioritized for organ transplant. I'm also a bioethicist, which means that part of my role is to try and critically assess reasoning and arguments. And also, unfortunately, for you all who have to listen to me for the next 20 minutes, to utilize philosophy, and I sometimes use metaphor to try and understand and unpack challenging issues. And the issue, as we are all quite familiar with, when we're thinking about this, is a problem of finite resources. There are not enough organs to go to everyone in need when they need it. And organs cannot be divided, except maybe livers, but those can't be divided enough so that each person in need receives an equal portion of the organ. This is an inequality. It's an inequality that requires rationing. Pediatric prioritization is policy, is utilizing policy to impact how organs are rationing. And as mentioned by Dr. Perito, the specific policies vary globally, but the net effect of any of these policies is to prioritize children to receive higher quality organs sooner. That's what pediatric priority is. In the United States, as Dr. Perito showed, we have a strong legal foundation of pediatric priority. Again, in the original legislation of the National Organ Transplant Act, which was created our national organ transplant system, it requires that the transplant system recognize differences in health and in organ transplant issues between children and adults throughout the system and adopt criteria, policies, and procedures that address the unique healthcare needs of children. But with my time, I want to focus on the ethical foundation of pediatric priority. And I'm going to go through 7 arguments, drawing in large part on 2 very important documents that are publicly available. The first is a white paper from 2014 written by the OPTN Ethics Committee, and the second is a position statement put out by the International Pediatric Transplant Association last year. These documents do differ slightly, but generally they both include 5 arguments in favor of pediatric priority. One is that it increases utility, which is a focus on outcomes and efficiency. That it improves fairness. So there's 3 different appeals to fairness that we'll talk about: the prudential lifespan account, the fair earnings argument, and maxi-min. And both documents appeal to a shared moral intuition that we all hold, that society has special obligations to protect children. I'm also going to talk briefly about 2 additional arguments: reciprocity and supporting the values of childhood, that aren't in those documents, but exist elsewhere in the literature. The first appeal is to utility, really efficiency. So this is a focus on outcomes. It begins with the observation, as mentioned by both of the speakers before me, that patient survival is greater on the whole for pediatric transplant recipients relative to adult transplant recipients. Recipients can live longer. Long-term survival is better. There are also arguments that children who are on the wait list have increased urgency due to their developmental state, lack of growth and development, that can result in greater or unique benefits from organ transplant. This argument comes up a bit more on subsequent slides. An additional appeal to utility or efficiency is that pediatric priority minimizes the likelihood that a transplant recipient will die with a high quality, highly functioning allograft inside their body, and that is an outcome that is an inefficient allocation of our limited resource of deceased donor allografts. Next, I want to move to appeals to fairness, the first of which is the prudential lifespan account. And this begins with the observation that early or earlier organ transplant affords a better quality of life and prevents the accrual of lifelong deficits in growth and cognition caused by pediatric organ failure. And these types of impacts are well described in growth in cognitive and psychosocial development of children on dialysis, also described in children with heart and liver failures. In the prudential lifespan account, philosopher Norman Daniels argues that we should make decisions about how to allocate a limited resource, like organs. When we think about that, we should think about how an individual would choose to allocate that limited resource if they didn't know what their exact age or life expectancy were, but had to make a decision about allocation across the stages of his or her own individual life. This is the concept of not knowing, of thinking about an ideal allocation system of this limited resource, of not knowing when it is applied if you may develop organ failure as a child or as an adult, where it makes sense for us to devote our resources. When blinded to one's own position. From this perspective, as a society, it's been argued that it makes sense to preferentially allocate resources to children and young people in order to maximize the potential for these individuals to thrive in early and later stages of life. And indeed, pediatric candidates have the potential to receive unique benefits from transplant that will positively affect their lives as children and later as adults. The next appeal to fairness is called the fair innings argument. It's a metaphor of a game. This was originally described by a philosopher named John Harris, who worked in England. I suspect Professor Harris was referring to the game of cricket. I'm an American, so I think of baseball. But really, when thinking about this metaphor, is really any type of a game with a set duration. The idea being that we're entitled to play the full game. If we play less, it's unfair. The fair innings argument holds that every individual deserves to experience a full life. An allocation of societal resources, like an organ, should try to maximize the opportunity for each person to receive a full lifespan. So if every individual is entitled to experience each stage of life, and if the elderly have had the benefit to experience each stage of life, and someone who is young has not had that benefit, then the young should be prioritized. To put this argument slightly differently, if we think of a 10-year-old and a 70-year-old, each with organ failure, both patients are equally sick. But who could deny that the one who has been healthy to live to 70 years is much better off than the 10-year-old with organ failure? The fourth appeal to fairness is called maximin, or refers to the maximin principle. This again comes from concepts of egalitarian justice and how to respond to inequalities. And as I said, the limited organ supply is an example of inequality. We don't have enough organs for everyone who needs them when they need them. In egalitarian justice, inequalities should be arranged for the greatest benefit, the maximum, to go to the least advantaged members of society, the minimum. That's where maximin comes from. And it's worth recognizing that children, because of their developmental state, are particularly vulnerable. They lack a voice and can lack resources. They may also be less advantaged because they are particularly harmed, because they've experienced limited growth and cognitive and psychological development while on dialysis or while living with organ failure. They can face size-specific barriers to transplant. They can face unique challenges in receiving life-sustaining treatments while awaiting transplant, and are at particular risk for premature death. It follows then that we should prioritize children to receive higher quality organs sooner. The fifth argument is an appeal to a shared moral intuition that children are special, they're vulnerable, and they deserve extra care and protection. When looking for evidence for the shared moral intuition, I went to international law. So if we look at the Geneva Declaration on the Rights of the Child, which has been subsequently reified as the UN Declaration of the Rights of Child in 1959 and 1989. This is probably where I also should have disclosed that I live in one of the two countries in the world that has not ratified this treaty, to its shame. I actually think, I apologize for the busy slide, but the language is really important in these treaties. That mankind owes to the child the best it has to give. The child shall enjoy special protection and shall be given opportunities and facilities by law and by other means to enable him to develop physically, mentally, morally, spiritually, and socially in a healthy and normal manner. The child must be given the means requisite for its normal development. The child must be first to receive relief in times of distress. And in the enactment of laws for this purpose, the best interests of the child shall be the paramount consideration. The sixth argument, or ethical justification for pediatric priority, appeals to the principle of solidarity. This is the idea of reciprocity. And this is an idea that was put forward by Dr. Lainey Friedman Ross, who is a noted transplant ethicist and wrote the textbook on transplant ethics. Dr. Ross made this argument based on an observation in the United States and also in a number of other countries around the world, that children as a population contribute far more organs to the deceased donor pool than they receive. This is data from the United States looking at kidneys and livers. On this side of the screen, these are the contributions to the deceased donor pool annually, and the number of deceased donor kidney and liver transplants annually. And the last argument that I want to talk about will be drifting more, a little bit more philosophical. So I apologize for that, but I promise I have a point. I think another barrier when we think about pediatric priority, or why we should prioritize children to receive higher quality organs sooner, can actually have to do with our perceptions of childhood and what childhood is. Because there is another societal held view, or at least a view that exists within the Western canon of philosophy, to consider childhood as a state of deficiency. Aristotle, for example, claimed that children cannot be happy, for they're not old enough to be capable of noble acts. When children are spoken of as happy, it's in compliment or promise for their future. He and more recent bioethicists, philosophers, and clinicians, including transplant clinicians, highlight that it's necessary to have the moral authority to decide over one's life in order to flourish, to achieve what's necessary. You have to be an autonomous adult. In this sense, children are imperfect adults. Childhood's a predicament, a comparatively regrettable but ordinary stage on the way to personhood, to become an autonomous adult. And it's our job as clinicians to help children overcome the experience of being a child and to develop rationality, autonomy, and other things that are necessary to make adult lives important or valuable. This has been described using a metaphor of a sapling, that children are like saplings. Saplings are small, weedy versions of trees, but if we support them and don't allow them to die, one day they might develop into a tree. I'm going through this at some length because if this conception of childhood is correct, it does not follow that we should prioritize children. Actually, the opposite is true. We should prioritize fully autonomous adults. But childhood and a healthier childhood is valuable. Being a child is valuable. Again, I should acknowledge, I'm a parent, I'm a pediatrician. I also was a child, which I suspect is true for all of us. But this is true, and I want to illustrate this through a thought experiment, one proposed by another philosopher, Dr. Samantha Brennan. Brennan asked us to consider a world without children. A pill is created that instantaneously turns all newborns into adults, skipping childhood entirely. Now, Brennan claims, and I agree, that we have a shared intuition against using such a pill that would skip childhood for ourselves, for our children, or for all children. We have that intuition because a world without children would be impoverished. And, more importantly for our discussion today, individuals who skip childhood incur a prudential loss. Childhood has value. Being a child has value. In contrast, if childhood really were a predicament or a deficiency, we should desire skipping it, our own, our children's, and other children's. So childhood and a healthier childhood is intrinsically valuable. What this highlights for me is that a focus, that first slide where we talked about utility and efficiency, the focus on particular outcomes of graft and patient survival and long-term survival is actually inadequate to fully capture the benefits of pediatric transplant. Because pediatric transplant helps children with organ failure to experience the values of childhood, which are different than some of the values for adulthood. So rather than strictly autonomy, the values of childhood can be different. These include being nurtured, the experience of dependence, care, of love, to play, experience discovery, wonder, and joy. An organ transplant, particularly timely organ transplant with a higher quality organ, by making critically ill children healthier and allowing them to experience a healthier childhood, supports these values. And I think in the interest of promoting time for discussion, I'm going to stop there. And again, I'll thank you all for your attention. And I very much look forward to our discussion.
Okay, thank you very much, Erin, for this thought-evoking presentation. Thanks a lot. So our third speaker is Dr. Chiawi. So Dr. Chiawi is a pediatric transplant nephrologist who works in Sick Kids Children Toronto. He is the program director there, and he is Associate Professor of Pediatrics, University of Toronto, He's a staff nephrologist, Division of Nephrology, Hospital of Sick Kids. He's a project investigator at the Research Institute at Hospital of Sick Kid Children. His current appointment, he's a clinical and hospital appointment. He's, as I mentioned, is the present director of kidney transplant. Dr. Wee has a lot of research and publication. His research interests evolve around complement-mediated GN and a lot of other work research. Dr. Chia is going to talk to us today about the current pediatric prioritization system in Canada.
Thanks,
The
Anoop,
mic is yours to you.
for that kind of introduction. Just to check, everybody can hear me and can see my slides.
Yes, we can see your slides and we can hear you well.
Cool, thank you. So I'm probably going to start with my conflict of interest slide. I was going to say that I have no conflicts of interest from a financial perspective as related to this presentation. But I would like to recognize my potential biases due to the fact that I'm a pediatric nephrologist and with an interest in kidney transplantation, and that my job is to put children's kidney health needs first. I'm also a member, representing pediatrics on the Kidney Pancreas Working Group of our organ transplant procurement agency, which is called Ontario Health Trillium Gift.Life. When I was invited to give this talk, I've been tasked to sort of describe how we prioritize pediatric recipients in Ontario and in Canada. So what I thought was I'd briefly outline the rationale and ethical framework for pediatric priority and organ allocation systems, but also realized that the speaker before me, Dr. Whiteman, has more eloquently sort of described all the ethical principles behind it. But I suppose my version would be a pediatric kidney transplant clinician's view on it, rather than from a bioethicist view on it. And then after that, I was going to outline the current implementation of pediatric priority in the Ontario kidney allocation system, which could be viewed as very similar and across the country in Canada. So I think there is a broad cultural acceptance that as a society, we have a special obligation to our children because of their vulnerabilities. And this is, I guess, first stated in the sort of Geneva Declaration, which was the first international human rights document to specifically address children's rights. It was adopted by the League of Nations in 1924 and later by the UN, I guess, recognizing and affirming for the first time the existence of rights specific to children and the responsibility of adults towards children. And so, as I mentioned slightly before, this is further reflected in the UN Declaration on the Rights of the Child, which was eventually adopted in 1989. Representing a broad moral acknowledgement that children are inherently vulnerable and are owed a degree of care by society that may exceed that which is owed to older members. And it recognizes that children are inherently vulnerable due to their age and legal status, which are present in addition to other sources of vulnerability, such as those experienced by children with organ failure, and thus serves as an ethical justification for pediatric priority in organ allocation, in that societies have a duty to ameliorate this disproportionate vulnerability. I might spend less time on sort of some of these ethical considerations for why children need to be prioritized, which can be grounded in these principles because it's been so eloquently covered by Dr. Whiteman. So in the prudential lifespan account principle, bioethicist Norm Daniel suggests that, argues that sort of instead of viewing children as competing for resources against elderly adults, one should instead appeal to a standard principle of rational choice and take from one stage of his life to give to another in order to improve life as a whole. So this principle imagines that a person blinded to his or her own age would make allocation decisions for his or her own life based upon how that person would invest resources across one's life. So based on this principle, it would make sense to allocate resources to children and young people in order to maximize the potential for them to thrive in the early and later stages of life. The next concept is the concept of fair innings, which considers that there is some span of years that we would consider a reasonable life for a person to have had, and that any quantity of life above this fair innings is considered a bonus, and everybody needs to be given a reasonable chance to achieve fair innings. And so if you have to choose between two people, choose the one who hasn't quite yet achieved these fair innings. Therefore, prioritizing pediatric patients for organ allocation allows for the greatest number of individuals to experience fair innings. But I think it's important to note that this fair innings argument is not an argument that young lives have greater worth compared to those of their older counterparts. I believe it focuses on minimizing harm caused by the premature death of an individual who has not yet achieved fair innings. And then lastly, the maximum principle accepts that inequalities are inevitable in the allocation of a scarce resource like donor organs, and makes a strong ethical argument that society should only tolerate these inequalities in organ allocation when those inequalities are organized so that they are the greatest benefit to the least advantaged members of society. And we recognize that children are inherently vulnerable, and children who suffer from organ failure are more disadvantaged compared to their adult counterparts for various reasons, including but not limited to time-limited benefits for growth and development and quality of life, the risk of premature death, as well as life support sort of treatment and organ replacement therapies like dialysis being more onerous for children, and that there might be less accessibility to some organ transplants in some situations when it comes to things like size mismatch. And so given that many of these effects are time sensitive and exacerbated with prolonged time in end-stage organ failure, delays in organ transplantation in children generates a disproportionate degree of morbidity as compared to their adult counterparts. And thus prioritizing children for organ allocations represents an effective means of addressing this disparity. Looking at some data from the kidney population, we know that children with chronic kidney disease have growth impairment. This figure is taken from a publication that looked at growth patterns after kidney transplant in European children. It showed that although there is some catch-up growth after transplantation, children who receive transplants at younger ages stood to benefit the most. And this highlights this time-sensitive benefit to growth for children that we should ideally limit the duration of time the child spends in advanced CKD or dialysis, and thus consider a kidney transplant as early as possible. Another European study documented that children on dialysis have poorer health-related quality of life scores compared to healthy children, and also compared to children with other sort of chronic kidney conditions. This seems to improve with kidney transplant, with the improvements being more marked in those who received a preemptive kidney transplant compared to those who did not receive a preemptive kidney transplant. Similar work done by Dr. Whiteman and his group further affirms that kidney transplant is associated with improvements in health-related quality of life within the first year following transplant. And importantly, compared to children who remain on the waiting list, those who receive a kidney transplant do have a long-term survival advantage. Within the first 6 months of transplant, there was no significant excess in mortality compared to patients remaining on the wait list. And after 6 months, the risk of death was significantly lower and sustained. And perhaps the simplest and most fundamental argument for pediatric priority for organ allocation is that an organ transplant helps keep children healthier. and facilitates the ability to have a healthier childhood and to experience all the values that are associated with it, essentially allowing kids to just be kids. As the previous speakers have highlighted, in the US, the National Organ Transplant Act recognizes this need and provides a legal foundation for the implementation of pediatric priority, calling for the recognition of the differences in health and in organ transplantation issues between children and adults. And that sort of, it's important that we adopt policies and procedures that addresses the unique healthcare needs of children. The Canadian equivalent of this is the Organ Donation and Transplant Collaborative, which was led by Health Canada. And then the International Pediatric Transplant Association also recently published its position statement in support of prioritizing pediatric recipients for deceased donor organ allocation. It is worth a read if you haven't read it. It is quite brief. It provides a succinct discussion around this key ethical justifications for prioritizing pediatric recipients that their recommendations are based upon. Okay, I'm now going to shift gears and share how pediatric priority is implemented within the organ allocation system in Canada. I have to say that it is less complicated than the US version. To give you a high-level overview of the healthcare system in Canada, we have a universal healthcare system. The federal government, through Health Canada, sets and administers national principles for the system under the Canada Health Act and provides funding to the provinces and territories, who are then responsible for administering and delivering healthcare services within their own province. I am based in Toronto, Ontario, and thus will share some information about our allocation system and specifically about our implementation of the pediatric priority within the kidney allocation. It is fairly representative of practices across the country for pediatric prioritization and kidney allocation, as they are based on very similar principles. So the Organ Procurement Agency in Ontario is Trillium Gift of Life under the auspices of Ontario Health. It is responsible for the delivery and coordination of organ and tissue donation and transplantation services across the province. As you can see, our current allocation incorporates sort of pediatric priority. The average pediatric candidate is generally prioritized quite highly after medically urgent, highly sensitized recipients, as well as previous living donor and multi-organ transplant candidates. And this is guided by the principles of balancing justice, medical need, and utility. And it supports the idea of that the sickest person and those with the greatest need for a transplant be prioritized to receive a life-saving organ. Within each different ranking category, pediatric priority is also given ahead of the adult counterparts. So for example, a child listed as medically urgent would get priority over an adult. And so the same is for HSP patients as well as all the other ranking categories. After that, the ranking allocation is further ranked by ABO identical versus ABO compatible pairs. And then within each group, further ranking is determined by allocation points, which incorporates time on dialysis and wait times and the degree of sensitization. In order to provide greater access to organ transplants, each province also participates in national kidney sharing programs for deceased donor organ listing and sharing. One such program for kidney patients is a highly sensitized patient program. This was established about 10 years ago by the Canadian Blood Services to increase transplant opportunities for patients needing very specific matches from deceased kidney donors and patients who are highly sensitized. To qualify for this program, patients will have to have a sensitization as measured by the CPRA of 95% and more. Within this program, the principles behind the allocation algorithm is fairly similar. It prioritizes the medically urgent cases, the sickest patients, followed by the highly sensitized 99 and 100% patients, who are the most difficult to match and thus likely to wait the longest, and then followed by pediatrics. Again, within these different categories, pediatrics are prioritized over adults. And this prioritization of the 99 and 100% CPRA patients is driven by data that shows that they are the hardest to match, as seen on this figure that was shared courtesy of the Canadian Blood Services. This figure estimates the approximate time to 90% match probability within the HSP program. And as you can see, for those with CPRA of 98% and below, the approximate time to matching is relatively short. For those who are 99%, the approximate time to 90% match probability is significantly longer at 20 months. And for those with 100% CPRA, you can see that they don't even reach 90% match probability and tend to wait the longest. Data from our province would suggest that the pediatric priority system is helping children get a kidney transplant earlier. As you can see from this figure, breaking down by blood group, the average wait times for children waiting for a kidney is significantly shorter than that for adults. And having a look at that difference in wait times between pediatrics and adults would warrant the question of whether adults are significantly disadvantaged. While it makes sense that prioritizing children ahead of adults do mean that adults do wait a little longer, I think the data would suggest that this is likely very minimal, as the proportion of children waiting for an organ and who go on to get a kidney transplant is very small compared to the whole pie of people waiting for an organ. However, I think I was going to end by saying that it is important to recognize that pediatric priority in organ allocation addresses just one type of inequity, and that an organ that is allocated to one individual or one group of individuals represents a missed opportunity for another. It is important to recognize that there are other types of inequity affecting children and adults in transplantation, such as those that might be imposed by racial and ethnic differences, gender differences, differences in socioeconomic status, geographic location, and that sort of affects specific groups like Indigenous people or children with intellectual disability and refugees. And they are also important to be acknowledged, investigated, and potentially mitigated against. So in conclusion, I think in my opinion, pediatric priority in organ allocation is based on good evidence and defensible ethical grounds. However, it is important to acknowledge that despite our commitment to the pediatric priority, the needs of some groups of children and adults are undervalued and may be impacted upon, and also warrants investigation and addressing. And I hope I provided a very high-level overview of our current implementation of pediatric priority for kidney allocation in Ontario. Thank you.
Thank you very much, Chia, for your excellent and comprehensive presentation. We have around 20 minutes for discussion. Please, again, I encourage any one of you who have any question to just put their questions in the Q&A box. We have around close to 400 attendees, which is a huge number. And so I'm expecting some questions. Maybe I'll start with the first question. How can we draw the line between giving the kids their priority versus disadvantaging the adult? Because this is the argument. Whenever we talk about the pediatrics, they're a vulnerable group, they have the right to be prioritized. The adult folks and adult colleagues, of course, everyone is advocating for their own, and I do understand this. But how can we draw the line between giving children their rights and disadvantaging other groups, including adults? Maybe Dr. Emily, can you take
Yeah, I
this?
think I can give a couple of thoughts on that are important for us to remember because we run into the same thing when we're discussing pediatric priorities. I think one of the important things to remember is what Dr. Chia just showed on the data, that for most organs in most systems, the number of pediatric candidates is very small related to the total number of adults. So even prioritizing all children, which there are many justifications to do, ends up having a very small impact on the adults. It takes a very small number of organs out of the pool, or, distributes them in a different way because the number of kids is so small. So the impact ends up being small on the adult pool. The other thing which is important to remember, which I think we saw reflected in the values prioritization exercise, and I think Aaron sort of mentioned in the ethical principles, is that especially with, and this happens to us all the time in the US policy discussions, because the majority of patients are adults, the majority of providers are also taking care of adults. And if we each come to the policy making discussion thinking about the best thing for our own patients, then there are usually more voices in the room who are connected to adult patients. That may be different in the way that your system structure works, but for us, that is true. What we try to encourage people to do, and I think the values prioritization exercise, encourages you to do, is when you're making policy is separate it from the patients that you're taking care of and try to think of the community at large, or the values of the community at large, where it's not, do I want the organ to go to my patient or somebody I don't know? But if I'm trying to prioritize between two candidates, is it my adult uncle or my child nephew that I think should be prioritized? And that's sort of how the values prioritization exercises encourage people to think. So I think that's important to think about in policymaking discussions too.
All right. We have a question from Dr. Mohammed Al-Maghrabi. Maybe I will put him live if he wants to answer, to ask his question. Go ahead, Dr. Mohammed. Dr. Mohammed, can you hear us? Okay. So I'll ask his question. He has a question regarding how can we expand the pediatric donor pool by utilizing small babies and infants?
So certainly on the kidney side, we've seen a movement towards using paired transplantation of particularly small kidney donors. But this also actually gets to a pragmatic policy question in the United States, which is one that Dr. Perito and I have worked on a bit on the OPTN side, which is that the way the KDPI scoring of deceased donors works is it classifies a pediatric donor in such a way that those organs aren't actually scored so that they, which is exactly what's written there, scored in such a way that they are recognized for being the high quality organs that they are. That is something that we continue to advocate for. And it is a flaw in the current system. Dr. Perito, I don't know if you have a different.
No, I would agree with you. I think it's why it's so important to follow the impact of these initial policies and think about integrating public comment opportunities, because sometimes there are kind of unintended implications of the policies we start with, and not grading these pediatric paired kidneys from very small babies as highly as they probably should be so that kids have access to those, I think, is one of those flaws. As I mentioned, our system can work slowly, and so it sometimes takes longer than we would prefer to implement some of these changes. Yeah.
Okay. There was a question regarding the definition of highly sensitized. And to be honest, currently in the current allocation system, we tend to have lower calculated PRA. We talk about 95 as a highly sensitized. Maybe Dr. Chia can get this question. in the Canadian allocation system, and I believe even in the US allocation system, the priority is only given to a very highly sensitized, 99 and 98%. What about 95%?
Yeah, so I think when our HSP program was established, it was, I guess, decided that the hardest to, I guess, match recipients were those with sensitization degree 95% and above. But I think, after 10 years of its implementation, we are, I guess, realizing and learning that what it's now done is that it's concentrated a lot of the 99 and 100% patients who are so difficult to match that they are waiting for a long time, even by being given this priority. And so there has been some changes in the system to basically try to prioritize the 99 and 100%ers even more. And I think it's also a little bit important again to recognize, like what I hope I highlighted, that I guess these are all arbitrary cutoffs based on, I guess, data and what we want to prioritize, and that there's always the risk of disadvantaging another group. And I think what we're also learning is that there's also the effect of blood group in terms of attributing to longer wait times that may not totally be reflected if we just looked at PRAs.
Right.
And
So
so there's work
sorry.
that we're trying to do to look at what we would consider functional PRAs, where we would take into account sort of ABO group and PRA.
So there's a question in view of organ shortage, what is the ethical, how can we balance between the shortage and utilizing a poor quality kidneys for pediatrics, like extended criteria donors or donors after circulatory death? From ethical point of view, knowing that these are marginal kidneys, shall we give it to children when we don't have alternative? Dr. Emily, Dr. Aaron.
I'm going to defer to Aaron on the ethical point of view on that.
Okay.
So I'm going to reframe this slightly, because if the question is that the child meets the definition that we use in kidney transplant for urgency, meaning they don't have any other access, then yes, of course, they should get whatever transplant we can give them. This is actually a question, I think, more about efficiency in terms of which organs should be made available for children, or which organs should be prioritized towards children. The answer is, I think, a little bit different. The one big exception being kidneys that come from pediatric donors or pediatric deceased donors, which, setting that aside, the concern of utilizing higher KDPI organs for children or allocating them to children is those organs are expected to have a shorter long-term survival. Our patients expect, with successful transplant, we expect long-term survival for them. We expect, hopefully, that their allograft will last for 15 or 20 years. And that's not necessarily the expectation for a higher KDPI scored kidney. Shorter duration, and the shorter the duration that the first organ transplant is in the patient, the more sensitized they're going to be for a subsequent transplant, the more their vasculature is going to be changed and impacted for a subsequent transplant. And in those senses, allocating higher KDPI organs to children is somewhat less efficient than a lower score. Sometimes that's been called age matching, which was an area of some debate in the United States related to the kidney allocation schema. But I think longevity matching is what ended up being how that is reflected in our policies.
Right. I have a question for Dr. Emily. it caught my attention that in the US allocation system, you're engaging public. And I think this is really intuitive. It is really wise because at the end, they are the ones who are consenting for donating. And it seems that every time public are with giving priority. So do you think for us in the kingdom, asking the public and engaging public is a good idea to promote for pediatric priority? Because we have, as all internationally, whether here or moral obligation towards an ethical obligation to our kids. So what do you think?
Yeah, I personally think it's an important part of our system. I think it increases transparency. So when there are changes coming, we have a sense of how they will be received in the community. Ideally, it then, also increases with that transparency, the sort of longevity of the policy. If people agree that, oh, we've thought about this change, it makes sense, let's see how it works, as opposed to, we didn't know anything about this, it got changed, and now we actually think there's other problems. So I think it's helpful for those things. The way we do this is the comments are posted, or the proposals are posted on the website, so they're available that way, and then they're presented at the UNOS regional meetings. I think we do still have limitations with like who knows to go access that information. So it is publicly available in that it is on the internet, and if people know about it, they know to look at it and comment on it. I think one of our challenges is always how do we reach those stakeholders effectively and engage them. Most of the people who submit public comments are engaged already in the transplant community in some way, but they are also like the sort of members and the users of the system. So it's nice to get their feedback.
Excellent.
I might add one other feature that I think is a strength of the kind of the OPTN UNOS system, is that each committee that I've served on, that Dr. Perito served on, has also had parents of transplant recipients, have had transplant recipients, have had parents of deceased donors or relatives of deceased donors. And that's another, and they provide valuable feedback, valuable insight, and frankly, valuable guidance in the work that we do. And that's another way of engaging with the public as we develop and refine policies.
What I'd add to that is that I suppose the public consultation and engaging the public also allows the opportunity to build trust. And I think a lot of this work that we do in organ donation and transplantation relies very heavily on public trust.
I think that's a really important point, right? It is a lot that we are asking of deceased donor families, usually after a terrible tragedy for their family. And so the transparency that we can establish in the system, and the idea that there's community feedback, I agree, is very important in terms of going into trust and trust building, trust in the system. And that has a big impact on folks that are willing to participate in the deceased donor system.
Sure. Dr. Perito, you talked about split liver transplantation, and it seems a brilliant idea to increase the pediatric donor pool. What are the challenges? Is it difficult? Why can't we do it? And why can't we put it in the allocation system for all hepatologists?
It's a good question.
It's a win-win situation, right?
Yeah. And many countries have decided that, where if it's a liver that's suitable for split based on donor characteristics and the anatomy, then they will mandate a split and allocate it to provide for 2 transplants. The long-term outcomes based on the data seems to be very similar for whole and split liver transplants, particularly in kids. The challenges, I think, go back to that point of like, are we making policy that's in the best interest of the entire community, or how much are we influenced by the specific outcomes at our center or the patients that we take care of? The splitting, there is time needed for splitting that can increase ischemic time. It can increase things like bile leaks, which makes you spend a few more days in the hospital. And those have an impact on, center outcomes and complications and cost also. So it is, I think, that the tension between balancing which are the most important priorities that hinders kind of making that a mandate within the US system.
Question for Dr. Chia. Do you think, from the slides I showed you, that we have only last year, we utilize only 126 disease organs. And I've shown that we have more than 20,000 in the list. So we're not talking about scarcity. It's way even more than very, very bad. The situation is very bad. So would it be ethical that we say, at the end, let's give the kids all these 126. It is very short, and the situation is different than US and Canada. The number of available organs is way less than US and Canada. We're talking about 126 for the entire kingdom. So would you think that still giving priority in this context is ethical? And Aaron also can answer. Chia.
Yeah, I mean, that's a challenging question. I think I would think that for sure what you're bringing up is that a lot of these considerations are contextual. It depends on your system. I mean, I would say that, yes, there's maybe more work to do in terms of trying to increase the available organs available for use in transplantation, but within that limited scarce, I guess, resource, there should still be sort of justification to, I guess, prioritize children, again, because of the fact that maybe children take up much less in proportion compared to adults. And maybe Aaron could build on all the ethical considerations on that.
Sure. Here's where, again, I disclose that I'm a parent, a pediatrician, and a former child. I want to actually highlight the kind of the big message that I took from your opening remarks, Dr. Alshami, that is a dramatic inequality in terms of the number of people on the waiting list and available deceased donors. The biggest take home from that is efforts, as you said, to promote is to promote the likelihood that deceased donor that deceased donation takes place. That it seems that even of the identified opportunities that a small portion actually end up as deceased donors, and that's something that we all support and all think is a good thing. To your question, kind of directly, I do think that children should be prioritized. I don't know that it follows that children should be prioritized to receive every deceased donor organ in any country. Children are a special population. They are particularly vulnerable, and I think they accrue particular benefits. I think kind of every country and often every region has their own particularities of their system. But in all of those where we prioritize children, there are other groups that we also recognize can receive particular benefits or face particular barriers to organ transplant. And it doesn't make sense to allow only one of those groups to receive organs, but I don't think that's, but it does follow that it makes sense to have policies and procedures that give children a higher chance to receive higher quality organs sooner.
All right. I think we don't have any more questions. And with this, I would like to thank all of the attendees. Still, we have close to 400 participants. And I'd like to thank our guest speakers for their phenomenal presentations and engagement and discussion. It was our honor to have you tonight. Thank you very much. And until we see you again in the next webinar.
Yeah.
Have a good night.
Thank you. Thank you, Dr. Anoud. On behalf of the Saudi Center for Organ Transplantation, we would like to extend our heartfelt thanks to our distinguished speakers, Dr. Aaron, Dr. Emily, and Dr. Shia for their insightful and thought-provoking presentations. Your expertise and perspectives have shed lights on the critical ethical and medical considerations in pediatric organ allocation. We believe that these discussions are invaluable as we continue to strive through fairness and improvements in this vital field of healthcare. Also, special thanks to Dr. Al-Anoud for moderating today's session and directing this whole great webinar series, and to our sponsors who make this event possible. Special thanks also to our attendees and participants who joined us in this important webinar. Let's continue working together to improve the lives of children in need of transplant, ensuring that they receive the care and attention they deserve. Thank you all.
Thank you. Have a
Thank
good
you.
night.
Thank you.
Thanks.